The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey, good morning, everybody. This is Eric back with you. Hope everybody's having a great holiday, great Thanksgiving. I'm recording this on the morning of Thanksgiving, about 6 a.m., and I came across a study, or actually a teaching that I thought really spoke to me. And it's a topic that we talk about quite a bit in both the ventilator management book, in our review course, or anytime I lecture on ventilation. But I can guarantee you it's something that most of us forget when we're actually taking care of our patients, and it's very, very profound. Obviously, I think a lot of times we do the best care possible, and unfortunately, though, we do little things, and it may be quite a few little things during our patient interaction that affects our patient negatively down the road. And we have to remember when we take that oath to practice medicine in whatever capacity that you're in, we're supposed to do no harm. We're not supposed to add more harm to our patient. So it's always important to kind of look at new concepts, even though they may not be new to the profession, but they may be new to you, and consider those concepts and try to employ those things when you're taking care of your patients, because truly those are those little minute things, and when you add them all together, that make a huge difference in your patient care and hopefully your patient's clinical course. So this concept is called absorptive atelectasis, and atelectasis is essentially collapse of the alveoli, and we know that collapse of your alveoli causes a big issue, and so I'm not going to relate this to traumatic collapse or a disease process collapse related to COPD or things like that. What I want to talk about is basically clinician-induced, caused from things that we do, and how can we maybe reduce the incidence of alveolar collapse. We know that alveoli are very, very sensitive. They need to maintain patency, and anytime they collapse, they just don't like to be reinflated. It just doesn't happen very easily. So it's very important to try to alleviate any alveolar collapse or alveolar atelectasis. So the concept here is pretty simple. The first thing we need to review is the gas law of Dalton's law. And remember, Dalton's law is also called Dalton's gang. Dalton's law is the gas law of partial pressure. So essentially, you have your atmospheric air, you multiply that by the percentage of oxygen that the patient is breathing. That gives you the partial pressure of oxygen. And we know as we increase in altitude, the atmospheric pressure actually decreases, and that reduces our ability to utilize oxygen. So an example, at sea level, our atmospheric air is 760 torr multiplied by 21%, and that gives us a partial pressure of oxygen of about 159.6. When we look at that, we actually think about bringing an O2 molecule into our mouth. We have humidification processes in our nose and our oral pharynx that actually dilutes that partial pressure down to about 104. So that's essentially our starting partial pressure of oxygen. If we went up to 18,000 feet, that would essentially be reduced in half. So essentially that's Dalton's law, and that demonstrates that at 21% oxygen, despite the altitude that we're at, we're still breathing 21% oxygen, but that 21% oxygen isn't the same as far as our ability to utilize that oxygen. Now, taking that a little further, we have to understand what makes up atmospheric air. And that's where this kind of relates to this whole phenomenon of absorptive atelectasis. When you think about how we breathe atmospheric air. It's made up of 21% oxygen, like I said, and then it's made up of primarily 78% nitrogen, and then other small inert gases at approximately 1% that really aren't important for this discussion. But our primary gas that we breathe is nitrogen. And so we have to remember what happens to that nitrogen. Where does it go? How is it processed? How is it utilized? Well, we know that as we bring in atmospheric air, we're obviously utilizing the O2 for gas exchange at the alveolar capillary level for utilization of that oxygen content, right? And we know that 2% of that dissolves in our plasma. The remaining amount dissolves and is actually transported on our hemoglobin to be utilized later. And we know that we actually produce about 1,000 mils a minute of oxygen, and that we only really utilize about 2% of that based on that dissolved in our plasma. So all those stores that are placed on the hemoglobin are just essentially for those events where we're exerting ourselves, exercising, hiking, things like that, or in an illness where we really need to utilize those stores. So when we talk about this concept and kind of relate it to why this is important, we have to understand and kind of apply it to how we're practicing medicine now. We've all been taught that, from the start of our career, that giving high concentrations of oxygen is always the best option. But we also have to remember, and if you're listening to this, kind of think back to when you started practicing, in whatever discipline you're in. If you're a doctor, you're a PA, you're a nurse practitioner, if you're a paramedic, a nurse, whatever you are, we all started at a basic level. And at a basic level, we're taught very basic concepts. We're not taught to look at things from an advanced perspective. They really don't want you to make decisions based on clinical judgment. They just want you to throw, something at the patient as far as high concentrations of oxygen, and that's kind of doing the lesser amount of harm, I guess, per se. But when you look at us as critical care providers, and I'm assuming the people listening to this podcast are either trying to transition into the air medical environment or the critical care environment, or they're already practicing at that level. And so we're expected to make those clinical decisions and really identify best practice, and that's why evidence-based practice and research is so important, to constantly be challenging yourself to read things, identify studies, identify problems in studies, identify relevant information. So when we look at this, we know that passive oxygenation is the standard now, right? We're not going to give a patient, a bag valve mask and bag them up, fill their stomach with air. So we're all about passive oxygenation. So how does that relate? Well, one of the things that we have to understand is when we give passive oxygenation and we RSI our patients, we've always been taught we're trying to cause nitrogen washout. Well, what does that mean? Nitrogen washout, remember, is all about the nitrogen that's left in the alveoli. So as we bring in that oxygen in our mouth, or that atmospheric air into our mouth, the O2 diffuses through the alveolar capillary membrane. And like I said, nitrogen is a very dense gas and it doesn't diffuse very easily. So it actually remains in our alveoli, and it actually is utilized as our intrinsic PEEP. So it helps maintain our alveolar patency, very, very important aspect of maintaining our intrinsic PEEP. And we know our intrinsic PEEP is between 3 to 5 centimeters of water. So very important concept to understand. In the RSI setting, we've always been taught we want to try to optimize oxygenation. We want to bring our PO2 as high as possible to kind of bias that time during the intubation process. And by doing that, we cause nitrogen washout. We basically cause such a high amount of pressure of O2 in the alveoli that it causes a diffusion of nitrogen outside of the alveolar level. And in the acute phase of things, that's not really a big deal. But what is defined as acute phase? And I found this kind of a education piece from the anesthesia perspective very, very interesting, because really that acute phase is essentially based on this data greater than 4 minutes. And so how does that relate? What is the concept of absorptive atelectasis? Well, essentially, absorptive atelectasis is the concept of a prolonged state of high concentrations of oxygen that cause that nitrogen to be diffused out, and there's no nitrogen left to maintain patency of the alveoli. And so I found it very interesting that less than 4 minutes of passive oxygenation didn't show any ill effects of any alveolar collapse. But greater than that, basically right around that 7-minute mark, there was a significant decrease in alveolar patency, and there was absorptive atelectasis seen in those patients just in that initial passive oxygenation kind of segment. So we have to understand that passive oxygenation is a great thing. We want to obviously optimize our PO2. We want to do those things, but patients don't need a lot of oxygen. So how does this happen? What causes a significant issue with these patients? Well, the first concept we have to kind of understand is a concept of hypoxic pulmonary vasoconstriction, or let's just say pulmonary vasoconstriction. Not really hypoxic, because we're not talking about a hypoxic state. Vasoconstriction in the pulmonary vasculature is essentially a lot of times obviously caused from hypoxia, but essentially your body does something to try to better perfuse, better ventilate as far as oxygenation wise areas of the lung that may not be getting good oxygenation. So, and we know that ventilation and perfusion matching is essential. So your lung is always trying to optimize that concept. And so theoretically, essentially what you have is you have a constriction process in that concept of hypoxia that basically causes an increased blood flow to other areas of the lungs that aren't getting good gas exchange. We know that constriction, though, then in a chronic situation, long term, causes further damage. But it's your body's process. It's your body's process to try to maintain homeostasis and cause a more efficient perfusion in areas of the lungs that aren't getting perfused. So we're always looking for equal perfusion and equal ventilation, or minute ventilation overall, in all areas of the lungs. So how does high concentrations of oxygen cause an issue? Well, we know that oxygen toxicity is a very relative, very evident concept in critical care medicine and ICU-dependent patients. And a lot of times when I teach this, I kind of refer to it as a more long-term thing. But I think interesting, regarding this teaching is that, they start seeing a reduction in alveolar patency after that 7-minute mark when patients are given that high concentration of oxygen. Just a reduction in FiO2 from 100%, 80% showed a significant decrease in alveolar collapse or absorptive atelectasis. How do we kind of manage our patients? Well, again, think about this concept from do no harm, right? And we have to understand that long-term high concentrations of oxygen, that's not the answer. Our patients, you and I, we don't need a lot of oxygen. We breathe at 21% just fine. We don't need 100%. And so your whole goal is to try to lower that FiO2 down as quickly as possible to maintain an O2 saturation of 93% on all patients. Obviously, you have your trauma patients that may be kind of suffering from that hypemic hypoxia. I can think of maybe a pregnancy patient, a pregnant mom that has, an issue, whether it's a trauma or medical. They need to have a higher PO2. They live at a higher PO2, but really all other patients really don't need that high concentrations of oxygen. So we have to be very, very careful. I think there's a very fine line to giving passive oxygenation and high concentrations of oxygen once they're intubated. And we really have to understand that our patients don't need that long term. So we have to provide that passive oxygenation early. Try to limit that. Obviously, the RSI shouldn't take longer than 4 minutes. And then put them on the ventilator, identify what their O2 saturation is, and then bring down that FiO2 as low as possible to maintain that O2 saturation of 93%. And you're going to reduce the incidence of absorptive atelectasis. One of the things that I find very, very interesting in this is that when you look at the new studies that we've talked about for the last 4 or 5 years of low tidal volumes, right? Low tidal volumes, lung protective strategy, higher respiratory rates. How does that translate to this concept? Well, we have to also understand that when we deal with lower tidal volumes and we're dealing with higher respiratory rates, we're also dealing with more dead space now that's actually translated interthoracically. So, we've kind of gone from a paradigm shift of high tidal volumes, low rates, and we were causing too much harm. And now we've gone to low tidal volumes and higher rates. And we have to understand, what does a tidal volume do as far as alveolar recruitment? You have to remember that PEEP does not recruit alveoli. Your inspiratory maneuver, your tidal volume that's delivered either based on pressure or volume, is what recruits alveoli. And so if we're actually reducing the amount of tidal volume that we're giving, then we're actually reducing all these dependent lung areas, these lung alveolar areas that are getting recruited. And so you have to think about this. We're reducing the amount of FiO2 that's causing this alveolar collapse. We're now reducing the amount of tidal volume that we're using because it's led to ventilator lung injury and ARDS based on studies. We're increasing the respiratory rate, and that's causing more dead space. How are we maintaining alveolar recruitment? So this kind of goes along with this, is we have to kind of maybe think about giving more PEEP to these patients. A 5 centimeters of water of PEEP is very intrinsic. Like I said, we kind of run between that 3 and 5. So don't be afraid to give your patients 5, 8, 10 centimeters of water of PEEP, because we have to think about, we got to maintain patency. We've got to maintain the ability for gas exchange to happen. We don't want to reduce that ability because that's going to cause further clinical issues. So how does high concentrations of oxygen, even in those low time states, like I said, greater than 5 minutes, 6 minutes, 7 minutes, how does that start reducing our ability to oxygenate, or what causes absorptive atelectasis? Well, we know that about 95% of the oxygen that we actually take in is processed and turned into water, and we utilize that in kind of two forms. We utilize that in the carbonic acid buffering system to attach to CO2 to make carbonic acid, and we also utilize that in the electron transport chain to convert to water and to drive ATP synthesis through the ATP synthesis pump. The remaining amount that we bring in is turned into free radicals, and those free radicals are the cause of pulmonary vasoconstriction. We know that those free radicals break down the epithelial tissues in our lungs. They break down the cytosols in the cell. They start attacking different things, and they start this inflammatory response. But the little things that happen prior to all those massive things that happen are basically, it causes pulmonary vasoconstriction. That leads to other issues, and that cascades and causes that absorptive atelectasis. So from the perspective of doing less harm, we need to remember, we need to give our patients that lung protective strategy. Start at 6 mils per kilo. Give them more PEEP than what we did normally. Reduce the FiO2 down to as low as possible. And you can do that very, very easily, not only by just reducing it down because we don't need it, but add some PEEP. Remember, you can go up to 5, 6, 7, 8, 10 a PEEP, and you're not going to have a huge reduction in vascular tone for these patients. Remember, recruitment is everything. If we're using lung protective strategies, we have to give more PEEP. If we're using lower FiO2s, if we're using lower tidal volumes to prevent absorptive atelectasis, we need to understand that we have to do those little things very, very well. Remember, PEEP maintains that patency. We have to remember that. Lower FiO2s reduce the incidence of the absorptive atelectasis. How does the concept of paralysis long-term, how does the concept of allowing a patient to have that muscle tone contribute to this whole aspect? Well, it's a pretty significant thing. Muscle tone in and of itself, allowing those lungs to inflate based on intrinsic breathing, or the patient being able to trigger their own breath in, let's say, SIMV, that actually reduces and prevents that alveolar collapse. So that means that we have to think about, are we going to give long-acting paralysis? And this goes back to the last few podcasts that we've done. When we look at long-term sedation, pain management, right? We have a lot of medications that are excellent. We have fentanyl, obviously. We have ketamine that's phenomenal. And I think it's very important to understand that there's a lot of misconceptions about ketamine. Hopefully, between myself, Dr. Mike Abernathy, Ming from the Farm Podcast, a lot of excellent physicians around the world. Hopefully by talking about this stuff, we're kind of reducing the misconceptions on ketamine. But ketamine does not impair lung muscle tone. It does not cause that alveolar collapse. It allows the patient to comfortably breathe and trigger on the ventilator. And so there's a lot of things to kind of consider when you look at, do we paralyze somebody completely, or do we keep them in a state where they can trigger the ventilator and have some muscle firing? I think there's a couple concepts here in conclusion that I found pretty profound. When we think about minimizing the gas, when we think about minimizing FiO2, two kind of statements really stood out to me. The first one, 100% FiO2 at the induction stage caused atelectasis at the 7-minute mark. It also says that 100% FiO2 at the induction stage, less than 4 minutes, or at that 4-minute mark, showed very little alveolar collapse. I think it's interesting to kind of look at this from the perspective of just a subtle change. And one of the things that he talks about in his lecture is just this subtle change substantially reduces the incidence of absorptive atelectasis. And so we can do these little things. We can provide good pre-oxygenation. We can employ these studies that we've learned from great minds like Scott Weingart and Rich Levitan, and look at the studies related to paralytics that was just released by John Sackles out of the University of Tucson regarding traumatic brain injury, and look at the whole kind of debate on long-acting paralysis. And the use of sedation and pain management, and the studies on delirium. All these studies are interrelated. All these things need to be kind of considered when you're dealing with your patients. And so I think in the end, we have to consider, kind of 5 core things, and I'll wrap up. Is number 1, pre-oxygenation is essential. We don't want to bag our patients, right? We have to understand Graham's law is going to provide optimal oxygenation using the passive oxygenation technique. That needs to be probably limited to that under 4 minutes, right? Well, that's been shown to cause the start of that pulmonary vasoconstriction and absorptive atelectasis. FiO2 as low as possible to maintain an O2 saturation of 93%. Remember, we don't need that high concentration. We don't want to cause nitrogen washout. Remember that lung protective strategies are great, and they reduce the incidence of ventilator lung injury. They reduce the incidence of ARDS and things like that, inflammatory response. But we have to also understand that that is our primary purpose of recruitment. And so if we're using low tidal volumes and higher rates, we have to understand we have to maintain alveolar patency some other way. And that is by adding PEEP, be more aggressive with PEEP. Adding more PEEP and reducing FiO2 is much better for the patient. We have to understand that we're giving higher respiratory rates, and so we're going to have some added dead space. And so, utilizing a 6 mil per kilo on your starting tidal volume, I think, is very physiologic and very, very good. Obviously, there are those patients that we have to go all the way down to 4 mils per kilo, but I think that's rare. And I think, we have to kind of consider and weigh the options. We don't want to go in excess. When we look at this from the perspective of paralysis, remember that having the patient have some muscle tone prevents this alveolar damage or this alveolar collapse called absorptive atelectasis. So kind of in the end, everything is grouped together. We have to think about this in stages of our treatment. All this can be done throughout the entire patient encounter, entire patient care kind of paradigm. And so think about this next time you have a patient that you RSI, you place on the ventilator. Think about this concept. It's not such or kind of related to more of a chronic, hours to days. This phenomenon, pulmonary vasoconstriction, absorptive atelectasis is a true issue. It can happen within the first 10 minutes of a patient encounter when giving high concentrations of oxygen. So kind of consider those things. I appreciate everybody's email, all the tweets. We're gaining followers on Twitter. That's been amazing. The ventilator book, if you haven't checked that out, you can order that through the website. You can order that through Amazon. It's still maintaining the #1 bestseller status in transport medicine. So very, very happy and humbled by that. So thank you so much for making this such a rewarding experience. Share this podcast with a friend, and we really appreciate everything everybody does. Hope everybody has a safe holiday week, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.